Hi, it's Matthew Holt with the Healthcare Blog, and I have two newcomers to the healthcare IT industry here with me. No, I'm kidding. Glen Tullman, CEO of Transcarent, Aneesh Chopra, CEO of Carejourney, and at one point, Aneesh was the CTO of the US, if you remember. If you can remember back long ago when there was an Obama administration. Gents, you got some news. Before we do that, remind me what both your companies do. So, Glen, real quick, what does Transcarent do?
So always great to see you. Transcarent is a health and care experience company. And what we do is we make it easy for people to access high quality, affordable care. And the way we do that for our members is really simple. Grab a phone, look at the phone, and you can instantly access 5 things. You can instantly access physicians in 60 seconds, 24 hours a day by texting. You can access low-cost pharmaceuticals. You can get information on how to get care at home or close to it. You can find the best place to have surgeries. And last but not least, complex care like cancer and things like that. You can get great guidance about it. So that's what we do. We make healthcare easy and accessible.
Fantastic. Aneesh, what does Carejourney do?
So Carejourney focuses on helping patients find the highest quality providers through organizations they trust. And we've historically been working with value-based care networks who are built for trust. And we are ecstatic to be working with Glen and his team to extend that capability to employers and employees throughout the country.
All right. Well, let's so tell me, what is the new announcement, the new agreement? What are you going to be doing together?
So I'll jump in.
Okay, either one you can start, but
I defer to my godfather.
So we selected Carejourney as our partner to empower our health consumers, our members, with information, high quality information about what Aneesh was just talking about, and that is where to find high quality providers, high quality partners, healthcare systems. And that's really important because, Matthew, you know this, we've been talking about it for years. In healthcare, complexity is the problem, simplicity is the answer. Our goal is to make it easy for people to access high quality care, but you can't do that without information. Healthcare is an information business, and there's 3 pieces of information we all need. One is, where is quality? Where are the high quality providers? Number 1. Number 2, how do we get to them, right? How do we actually access that care? And number 3, what's the cost of that care? So finding a provider who we could trust, first and foremost, who our members could trust, who could provide us not just data, but actually do the best-in-class analytics about that to turn that data, that quality data information, or that quality data into information. That's what the partnership's about. And we had talked, we had experimented for years, and we decided to go all in with Carejourney and use them as our quality partner for providing this information.
So, Aneesh, how do you do that?
Yeah, so let me back up, Matt, and just give you a little bit of context. Go back to the Affordable Care Act, Section 10332 of the Affordable Care Act. Okay, for our policy.
Everyone knows what that is.
Everyone knows it rolls off the tongue. It called for the CMS team to release Medicare data for the purposes of provider performance measurement. And we're a decade into that legislation, and there really haven't been consumer-facing products and services that have lived up to the promise, because really multiple ships passing in the night. We've had a long-standing reliance on traditional, call it, Yelp reviews. You go Google on the internet, you kind of see what is essentially like, is the room clean and so forth. We've had survey data that's been a proxy for it, but we really haven't had a kind of ubiquitous model of data-driven measurement for cost and quality. And my role has, up until this moment, has largely been a bit more behind the scenes. The use of the publicly available data, my theory was that we use publicly available industry accepted algorithms to run on publicly available data. So there's trust built into the process. and that we had historically worked with, and we continue to serve 150 mostly risk-bearing networks who use the cost and quality information to help them organize the care teams to go into Medicare value-based care risk. We've been building out our data sets. We've been building out our relationships. To Glen's point, you got to relate the physician to the facility so you can do a better job of understanding how care teams build quality. So we've been working on these issues for years, but I had not yet had a partner who's dedicated and focused on exactly the three challenges as Glen outlined. So our thesis was there's going to be a moment when this is going to have to be brought into the hands of the consumer. And while we are continuing to build the data quality reporting and analytics, it needs someone like Glen to put it in context, to combine with access and cost so that it makes it relevant for people, so they can make true judgments about where the best quality and high value care is within the context of their neighborhood. And so I'm eager to support more people, and Glen's clearly got the right problem to focus on. And as you can imagine, is building an incredible team to execute on this plan and is moving really fast to make impact. So it's for us about extending a lot of the mathematical work we've been doing for value-based care networks with technical tweaks, because it doesn't just flip overnight. We have to really build it to the experts that Glen's team has assembled. So we're positioning this as a partnership to continue to fine tune the algorithms, the data sets that can be relevant for the broad commercial employee population.
So I want to dig into this in a second, but first there's a quick nerdy diversion I want to go on with you, Aneesh, because we can't talk about Medicare data right now without discussing the difference between fee-for-service data, value-based and Medicare Advantage data, and what is going on there, and upcoding, downcoding, all the rest of it. So the data that you're getting, is that just fee-for-service data currently that you're using?
No.
Explain the different types of data that you're getting, and then tell us if Medicare Advantage is a fraud or is like the greatest thing ever. That's a separate question.
I wrote a comment letter on it with Mark McClellan, and I'd be delighted to walk you through. So let me start with first principles. Congress asked for the fee-for-service data to be made public. The Trump administration doubled down. So this is one of those things, Matthew, this is a bipartisan make the system.
I know you love that stuff.
And I care deeply about where do we stay within the 40-yard lines, as President Obama used to say. Within the 40-yard lines, we can get a lot done. So the Trump administration added Medicare Advantage and Medicaid. So we've been interacting with about 140 million linked longitudinal records, which is a sizable share of the physicians panel. And about 4 years ago, we began onboarding commercial data sets. They're not the same as the publicly available data sets, which are clean, regulated, with very strong rules. These are data sets that you commercially access. And many organizations, you've interviewed many over the years, who've similarly purchased commercial data. So we combine roughly 270 million basically patient longitudinal records, and we run them through what we consider to be a library of the best appropriateness of care, quality of care, call it appropriate utilization of care. So there's a menu of quality measures that are critical to answering the question, and we run it on a full data set. The data sets are different, and we'll get into the details. The country desperately needs an all-payer claims database. The Lower Healthcare Costs Act of 2019 had it exactly right. Employers and employees deserve access to fair apples-to-apples comparisons in the same way that Medicare has released it. The employers need to. That is bipartisan, but hasn't passed yet. We got to work on that. But in the meantime, Glen's team has expertise in this population, and they've been working with us to make sure we can fine-tune the models to meet the expectations for employees around the country.
So Glen, when your team at Transcarent is saying to, you have an employee on the line looking for something, how much do you think that the kind of data that Carejourney and Aneesh is providing is going to be, are you going to deliver it to them? Or is this pretty much to help your team, the Transcarent team, the doctors and folks you're working with, direct them around? I'm back to the locus of where is the consumer making the decision in your system? Where do you think that's going to happen?
Yeah, the answer is wherever they want to make the decision. So like the rest of the economy, we have to put people back in charge of their care. People talk about consumer focused as if it's a gratuitous thing. They might focus on the consumer. What we talk about, consumer directed, consumers are in charge. So think about a ride sharing app. You decide when you want the car there, what kind of car you want, which way it's going to go, how you're going to pay them, everything you're in charge of. Think about healthcare in that same way. So someone looks at their phone, they don't have to call us, they don't have to talk to anybody. It's the middle of the night. They can access all the quality information. They can come in and they can basically put in a diagnosis. They can get immediate feedback. They can be texting with a physician instantly in 60 seconds or less. And then that is all based on quality, which is for the first time they have access at their fingertips to real quality information. Now, our people use it as well. So if someone wants to talk to a human, they can do that. That's available as well. It's not press 1, press 5, press 7. It's putting people in charge. And in the rest of our economy, you're in charge of your travel. We think you can do that. We think you can manage your money anywhere in the world. When it comes to health information, there's been a myth that we don't know how to do it. But, Aneesh talked about it before, and he talked about this idea of where do people get this information? Think about it. Today, your knee hurts. You might go on the internet, but you might ask a friend. You would call a doctor if you know a doctor. And that's just not the best way to run our health and our healthcare system. So we're going to actually add real quality to it for the first time. And, again, give actual members the ability to identify the physicians, the quality, and the like. Interestingly, if you move the bottom quartile of quality to the top quartile, you also drive the cost down, which is amazing. Higher quality care at lower cost. That's always been the dream. Now we can do it with a combination of technology, great data and analytics from Carejourney, and last but not least, actually still involving physicians, but letting them do what they do best, make judgments, deal with really difficult challenges in healthcare.
All right, so let me give you an example of what happened to me, and then I want you to translate it into what would happen now. So I am a member of a cheap concierge care service that you know very well that Amazon now bought. So the other day, because I'm an old man, I had a weird flashing thing in my left eye, and I went to the Mayo Clinic website, and I thought I self-diagnosed that I was having a detached retina. This was a little scary. Of course, I went to bed, woke up the next morning, still there. Got on the urgent care video line with a nurse practitioner. And here's where things fell apart a bit. They said, yes, you probably need to go and see your ophthalmologist. I said, well, I have very good eyesight. I don't have an ophthalmologist. And then it went, and I thought, well, surely. So I ended up, Googling a bunch of ophthalmologists in my neighborhood and calling them until somebody could see me because I thought it was quite urgent. What would have happened if I was a Transcarent member and called?
So what would have happened is you would have looked at your phone. You wouldn't have had to go to a separate site on the internet. Look at your phone, put in whatever those conditions would be. You would then get to do a medical search as you did, and you would self-diagnose if you so chose to do that. And then you might say, but you know what? I need to talk to a doctor right now. You would then literally touch another key on the phone. A physician would come up within 60 seconds, and they would say, Matthew, we see you've been looking at, you've been searching on the app. Here's what you were searching for. And you're probably calling about your eye. You would say, yes, I am. At that point, they'd talk to you about it. They'd say, maybe you should have gone to sleep. Maybe you shouldn't have gone to sleep. They would give you guidance right then and there. You wouldn't have to wait till the morning. They may conclude that you need to see an ophthalmologist. At that point, you could continue, and they would continue that search for you, with you, while you're on the phone, to find high-quality ophthalmologists in your area who have already been pre-rated by the Carejourney software. So we don't say somebody's bad. We simply show you the good folks based on the Carejourney analytics. And now you have a few places to go. And all of that would happen in one. You wouldn't have to re-explain yourself. You wouldn't have to go to multiple sites, all in one place. And we'd even go as far as making an appointment for you if you'd like us to do that. In some cases, not a lot yet, I want to be clear, but in some cases, you could literally book that appointment right online. And let's just say you had a behavioral health issue. At that point, you could get access to behavioral health digital care and also book an appointment in a shorter time frame than weeks, not weeks, but days or less. So again, we're making all that care available in one place.
And if you don't mind, Glenn, I might just for Matthew,
Please.
let me drill a little bit into the underlying math because
Sure.
I think he gets a little bit more in the weeds. The specialties that you search on the internet today are broad. Ophthalmology is broad, it includes retina, includes, on the back end, it could have glaucoma, it could have those that have macular degeneration. So you got many flavors of what quote unquote ophthalmology is. So step one, what Carejourney has done is by looking at our library of 270 million claims, we're adding a bunch of labels to specialists based on the patients they treat, the conditions they treat, and the procedures they render. So you've got two cuts at identifying what the right quote unquote ophthalmologist by category is. Then to get to the quality, as Glenn outlined, we believe in open source standards. So CMS funded the episode grouper for Medicare as an example, and that went to Brandeis University, and it was developing about 1,000 condition-based and procedure-based episodes of care. And unlike the rest of the vendor community, which are proprietary models, this is completely transparent so that doctors can evaluate it, adjust it, make it better. And it'll evolve, by the way. You'll see news about this called the PACES Center. PACEScenter.org is not formally launched in a big way, but it's on the web. You can look at it up. And so we are early partners to make sure that that kind of mathematical grouping is available. So you can understand you've got a group of patients that are in these either condition episodes or procedure episodes. You can identify the total cost of care and what the medical societies have deemed to be quality measures that you can run on claims data. And then we basically index within a geography what the observed to the expected performances at that physician level, like for like within those categories. And that allows us to create this, what Glenn is describing as the profile of the higher performing ones, which could be given all the Transcarent capabilities, much stronger access, relationships, better pricing. That's all the engine that Glenn is building to build out a high quality network nationwide, in part can unlock the consumer experience when you match up those that are right for you, given the clinical condition that's much more granular than searching on the internet ophthalmology.
And let's go back to your specific question though, because the system took you to a certain point and then it just dumped you back in.
Sure.
So that wasn't helpful.
That's the experience of most people in healthcare in America, right?
Exactly. And frankly, that's what navigators do. They navigate you to a point and then they just drop you off. And it's like, okay, here's what you need. And now you're on your own again.
But noting for the record, it's taken Glenn 20 minutes to get to criticizing navigators.
That's it. Thank you. But what we do is we're following through the whole way. So a physician who you may be texting, they're looking at that same data and say, no, specifically, here are the docs in this category that are treating specifically what you've described. And now you're directed to high quality docs in the right category, not just high quality docs. So you get that level of analytics involved, and we're with you for that entire episode until it's done. And that's really the difference. And so that's the entire follow through the process.
Yeah, look, and I've been preaching this forever that people to some extent they want that help getting there, and it's very helpful data. I've been through this recently with my eye, and I had an issue with my back, and the pressing one and leaving a message hoping somebody will call you back is the standard of care at most academic medical centers. And it's where we are. But there are two areas where you can see people are making leaps, and you're involved in both of these, Aneesh, obviously now with the relationship with Transcarent. One is better service for employers, and they're big employers and employees, big employers that Glenn's working with. And the other is Medicare Advantage. And the Oak Streets and the IORs and the other of the world.
All of them are Carejourney members. Okay.
So put your public policy hat on again. I know you really take it off. How is that doing compared to the rest of Medicare Advantage or Medicare fee for service? How good are we getting at really delivering that kind of intensive help that those people need?
So right now, we have mixtures of both. There's error bars on both ends. So we use these very crude mechanisms of identifying patients that have certain needs. Claims-based codes, diagnostic codes, are the currency of Medicare Advantage. Transactional codes, procedural codes, are the currency of fee-for-service. They're two different financial systems. And as the proverbial statement goes, show me the incentives and I'll show you the results. So what you have here is undercoding of underlying conditions in the fee-for-service system. So we end up with 30 or 40% of the people who get their first diagnosis of kidney disease in the ER before they go on dialysis, which we should have been doing for preventive care. Alternatively, you have individuals that say things like, this person is diabetic, but they have complications. And what's the line between those that are diabetic with complications and those that are just diabetic? Well, you add a few words, codes, and you might get a higher revenue. If it's the same person and they're moderately ill, but they've got some gray area codes, this is what referred to, Matthew, as upcoding. However, if you go into the EHR systems at Oak Street or some of the other folks that I have great respect for, they're actually documenting the clinical needs of the patient in the EHR. And they're demonstrating that that particular patient is much more likely to have downstream need, and they're building the care programs to reduce the kind of observed expenses against what would have been expected otherwise. I'll give you one small example because this is a little bit of a personal history of mine. You might remember we did this $1 billion healthcare innovation challenge. You've been my partner on challenges, challenge.hub. We did the healthcare innovation challenge at the end of the Obama first term. This is when I was still there. And it was the foundation for the YMCA diabetes prevention program. And the actuary did the study and had the following conclusion. The HCC code, or the condition code of pre-diabetes, is such a broad word. There's no predictive power of someone that has pre-diabetes if they're going to cost the system more next year. However, if you have pre-diabetes with an impaired fasting glucose of 110 to 120, it's a clinical value. You're very likely to get to progression to diabetes, and then you have a $2,400 expected cost. So a $600 voucher to the YMCA to avoid full-blown diabetes, it's a 4-to-1 ROI. So the actuary said, let's do this. So the fight you're seeing in Medicare Advantage is we're fighting with the blunt instruments of claims data. We haven't brought in the impaired fasting glucose into the system. Yet Glenn, we've been doing EHRs for the last decade. So Matthew, I am on the side of there's no heroes, there's no evil. There's probably a mixture of both that are the financial incentives that we're in. Objectively speaking, the patients that are pre-diabetic that have this impaired fasting glucose are expected to get crappy care, and we can put them in programs like Oak Street and Iora to get them better care. Let's do that. So that's where I come out. And so McClellan and I wrote this paper. We said, look, the current proposal has an adverse effect on underserved populations. That's not the Biden way. Someone didn't do their homework. That got kind of janky. I think they're going to correct for that. We'll see on Monday. But let's move forward with the right clinical answer and start bringing in the EHR data into the Medicare Advantage risk adjustment process because it's the right thing to do.
What about the instances where the whistleblowers are saying the ER data itself is being manipulated?
Look, here's the issue.
I've heard that.
Yeah. And look, at the end of the day, I'll let Glenn describe this. Physicians have control and rights and responsibilities for what they put into the system. If there's decision support and something shady where like, hey, by the way, buddy, you forgot to add blah, 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 maybe you could infer that the decision support logic was tuned for the wrong things. But fundamentally, the liability sits with the doctor for how they interact with the medical record system. So is that right, Glenn? Remember that? When they enter stuff, they own their liability for it. So
that's right.
Is that the health plan's fault? There's a lot of gray area here on who, they gave me a report that said add these things. That's not good.
I think, Matthew,
Sorry, Glenn, just one last thing on that. So, and I'm going to come back to you about the sense on the employer side, but what's your sense, Aneesh, about the sort of rate of change of people getting into those systems compared to the rest of Medicare fee-for-service and Medicare Advantage? What share of Medicare Advantage looks like it's doing well to you rather than
Yeah, I want Glenn to come in on this, but sticking with the Medicare policy side, objectively speaking, the market is voting with its feet, and we're on the cusp of the 50% range. If you're African American, you're underserved, we're in the 65%. So that ship has sailed. The key question for me is, can the CMMI team build in ACO REACH and other total cost of care models effectively a public option for truly managed and coordinated care? And so I'm on team public option for Medicare coordinated care. And that's why there's 100% value-based care goal by 2030. And that is not yet taken liftoff in the same pace as we see the MA plan. So we're going to have to do a little bit of that balancing act. And so all eyes on CMMI to get us a program option that's going to give that same coordinated experience that doctors are going to participate in.
And Glenn, on the employer side, well, two questions. One, on the employer side, how are we doing into programs that are like Transcarent and others that are sort of more coordinated rather than people wandering around? And then obviously other questions, do you have your eyes on MA as well, or ACO REACH?
Well, let's start with the employer side. So first and foremost, I think we're heading to a tipping point here. And the tipping point is that right now this year, projections are showing 6 to 8% increase. But the expectation is that's going to happen 3 years in a row. So 6 to 8%, 8 to 10% next year, back to 6 to 8%. So on a cumulative basis, that's an 18%-ish kind of raise. Employers are throwing their hands up and saying, look, we can't afford it anymore. We can't run our business. Mary Barra from GM said, we are actually a health benefits company that also makes cars. She said that because they're spending more on health benefits than they are on actually R&D on their vehicle fleet, which is extraordinary. Howard Schultz made the same kind of comment. We spend more on healthcare than we do acquiring coffee beans. So all of that is happening, and employers are actually looking and they're saying, what we've done over the last 20 years hasn't worked. We need a different solution. So that is driving it. Now, that said, they know that point solutions work. And some of the employers we deal with, the large ones, have 30 to 40 different point solutions. That's added to the complexity and confusion. So now they're back to saying we need something different. At Transcarent, what we're doing is we're going fully at risk, not give me $1 million, I'll put 100,000 at risk. We're going fully at risk. We're providing this experience, and we're putting it in the hands of consumers. And we think consumer-directed care is going to be the way to do it. Now, we have to solve this for employers because, as you know, they're essentially subsidizing the other side of the equation. One other thing I'd say is we have to open up the information, much as Aneesh did when he was in the government. We're going to see some of this. I think you're going to see legislation, but we still aren't seeing the sharing that allows, payers like United are not openly sharing their information. And that's making it hard for employers and others to get the information they need to make the right decisions. So we're going to have to see progress. I think the government is going to step in and to say you have to make this information available to employers, to third parties, and most important, to the members, the health consumers themselves. Then once you make that available, then it gets back to answering the question. And you said, look, there is plenty of blame to go around. And I'm with Aneesh. Let's not focus on who did what in the past, who we want to blame. Let's focus on what the solutions are. There's people who overcode. There's hospitals that overcharge. There's all of that. The more data we have, the more we can figure all that out and make it very clear. And it will be clear when we have the data available. We have great analytics, but we've done it in every other industry. We have to do it here. So we're going to stay focused and transparent on the employers. We think they are going to actually drive a lot of this change. On the other hand, what I will say is we've seen the government innovating in many respects, and that's very healthy. So I think it's going to come together in part because it has to, because healthcare spending is crowding out education and infrastructure and defense spending, and we can't do that anymore. So employers have said we've had it. They're going to try anything they need to do to address this problem. And we initially saw it in Haven, You can talk about why Haven didn't work, but what Jeff Bezos said was there is a fundamental lack of alignment. The more we spend, the more other people make. That's what we're starting to address. And I think it's going to happen with all the new technology that you see coming out. And I think it's going to happen pretty quickly. We've seen dramatic change with PBMs. 5 years ago, there were 3 PBMs. They dominated the world. Today, we hear all these new names that we know. We hear GoodRx, we hear Roe, we hear Capsule, we hear PillPack. I mean, Mark Cuban's starting, for God's sakes. You know, celebrities are starting PBMs. Why? They're all consumer focused, and consumers are taking charge. And now we're going to see that in the rest of the healthcare system. So it's what makes it exciting. But to do that, you need information first and foremost on quality, the single most important thing. Because if I say it's lower cost and it's your child, it's, you know, then you don't care about cost. You want to know, where can I get high quality care? Where can I get access to it across all our populations? And where can I get it cost effectively? That doesn't mean cheaply, by the way. And that's not what employers are saying to us. They're saying, tell me about good quality care, a good experience, and make it available to my people. Because right now, there's a competition for quality labor. And that's a good thing. And it's going to drive quality care.
So I think, interpreting you saying that you're not heading to Medicare or Medicaid yet, but I am seeing Point Solutions and other folks who are doing things in Medicare and Medicaid, you know, which have not traditionally haven't been done. So I assume there are things that look somewhat like Transcarent might start appearing there if everyone's.
Yeah, we have a lot to do, and we're going to stay focused. We're going to prove the model, and then I think it can be it can be incorporated anywhere. You know, interestingly, telehealth, when we talk about telehealth, you know, I think technology brings abundance. So what telehealth did was it opened up access to people in rural areas, to people in inner city areas, and frankly, internationally. What Google did for information, we're going to do in a broader sense for healthcare. We're going to make it available. And when we make that available, as we use AI in smarter fashions, I mean, it's part of the reason we acquired 98.6. They had a few-year lead on using AI to take some of the mundane stuff out of the basic interaction to allow physicians to refocus on what's important. We think that's great. And the more we do that and use it intelligently, the better care we can provide to everybody. And that's what, you know, interestingly, while I love some of the folks we've mentioned that provide concierge care, you know, we're talking, our customers are folks who work at Albertsons stocking shelves, UPS delivering packages. This is the heart and soul of America. And that's what we're delivering care for and improving the care experience to make it more affordable. Because healthcare remains the #1 cause of bankruptcy in the United States. We got to address that. We got to address that for the people who make America work. So the folks at Costco and all these places we love, we got to take care of the people doing the work. And that's what we're doing at Transcarent. So, and we're using Carejourney quality information to do it.
So you mentioned, I was going to get there, Telehealth 98.6, which you guys just acquired. You acquired the medical group and the technology, and they kept the technology. Can you explain the deal a little bit, and then explain?
Three things, really simple. One, first and foremost, the AI-powered front-end virtual care technology. So that allows you to automate a lot of what physicians don't want to do, gathering information. What pharmacy should I send it to? All those questions that physicians do over and over again, and it's a waste of their valuable time. So makes it more efficient. We got the technology, #1. #2, they're basic customers. There's a lot of folks who are using this, really top organizations around the country, the Boeings of the world, and, you know, Red Bull, which powers you, I know, Matthew. You know, we gotta, you know,
me and my race team, yeah.
But what they said is it does, and it's the problem you mentioned before. It's the front end, but then what? And so they were looking for, how do we complete the transaction? So that's where we come along. So the front end technology, a great base of clients that we're going to continue. And that's, by the way, not just employers, that's also payers. Some of the top payers, Primera, a great payer, Aetna Banner, which is a really interesting combination of a provider and a payer together, innovatively doing things. And then health systems as well. So we got that. And then last but not least, an affiliated physician group. And that's just going to help us fine tune and better understand the quality, go back to the quality, because, and you don't buy them. There's corporate practice of medicine. We have a very close relationship with this affiliated group that's delivering a lot of the care. So, I'm spending a lot of time with them, learning a lot about the quality side, because they helped build the models that all this AI was based on.
Is Transcarent using other telehealth services before? I know at one point using Cirrus and others, or have you now switched that entirely to the new group?
Well, we're bringing that internally where it makes sense. And we wanted to own the front end of that interaction, because the front end is where it all happens. We know it has to happen in less than 60 seconds. We know it has to be a very high quality interaction. And we want to provide the physicians when and where they get involved with really high quality information. So having that ability to control that front end is really critical to us. But it's not really about telehealth. It's more about this experience that people are going to have. And it's well beyond kind of the basic telehealth, which has become appropriately a commodity. I think the other thing I'd say is this is all moving to text, because when we talk about somebody delivering a package, working in a warehouse, they want to do what they use their phone for. They want to do everything on text. And there are more texts done in a single day than there are telehealth visits in the entire year. So that's the way this is going. It drives efficiency, and you've got to improve the interaction for both the member, the patient, but also for the physician. We have to make sure that we're making life better for our physicians too, because they drive the quality in the system too.
So you mentioned AI. We got a long way without mentioning AI in this conversation. Aneesh, obviously AI, one place it's started and clearly it's going to get a lot better with the ChatGPT-4s and all the rest of it is in that sort of front-end chatbot interaction, which used to be, has traditionally been terrible and is clearly going to get a lot better. The other place is in data and analytics. What is changing your business because of the sort of new wave of AI? Has it hit you at Carejourney yet, or have you been doing? What are we going to be able to do with this data that we couldn't do before? Because this new
Matthew, my first job out of college was at Morgan Stanley, and it was at a time when my colleagues on the tech team took Netscape public. I was giddy, and I've been giddy ever since about the power of the internet to affect public good, health, and other sectors. I'm probably 5 to 10x more enthusiastic about this moment in time. It's going to change almost everything we do. Now, on a practical level, there's more of a niche Carejourney policy advisory type discussion. It's just how do we think about all the government documents today that are not really loaded up into these systems. So, for example, all of the machine readable files that are available for price transparency, or all of the provider directory APIs that are required by Congress to make available in a machine readable format. Imagine we could unleash the LLMs on pulling that information in long before we get to like, who's the high quality doctor? Don't I want to know the phone number, the address, the accurate information? So I think we're going to get like a pretty clean data set on account of the capabilities. But the other piece is more and more of these point solutions are basically powered by benefits. So if patient has X criteria, then they qualify for chronic disease program 1, 2, 3, or supplemental benefits for social needs, or take your pick. And so I think, the legacy transactions for eligibility verification feel like tiddlywinks compared to what we're going to do to say, you know what, this person in front of me has all these all these needs, and the public benefits are available, plus the insurance benefits are available. Let's do the right thing for them. Imagine if we had full visibility on that patient's underlying conditions and the eligibility to all the services that they're entitled to. Imagine if Glen's team could match every person to the full suite of services, whether they're funded by the Transcarent partnership with the employers or gets people enrolled in food stamps or other service benefits that are available. I call that, Matt, the health information fiduciary market. And I am obsessed with growing that market and being a supporter and really a partner.
Yeah. And let me just add, let's take a really simple transaction. And that is you call in and you type in and you say, my sinuses hurt. Okay. So then you get asked a question back and it says, any other symptoms? You say, I have a headache and I have colorful discharge. Sorry about that, from my nose. And then it comes back and it says, I've looked in your records. You had 2 sinus infections in the last 2 years. Sounds like it might be a sinus infection. Most doctors would tell you those 3 symptoms lead to a sinus infection. So then it says, when you came in the last 2 times, we gave you a Z-Pak branded, and we gave you Zithromax unbranded. Did both work? You say both worked fine. You say, great. We noticed that you went one time to Walgreens, the other time to CVS. Where would you prefer to go? Or it can be delivered to your house, the prescription. And you say, well, I'd like to go to CVS. So fine. Everything I've just described has been done by a bot. You haven't involved a physician yet. And most physicians would say, I see 5 or 10 sinus infections every day. I know it when I see it. Here's the indicators. You don't need me on to do that or to do a UTI or other things. But at that point, the physician would get introduced. However, and this is what Aneesh was talking about, we also say, by the way, you're over 50. I noticed you haven't had a shingles shot. You really should. I notice you're down, 1 vaccination. That's available for you. When you go to pick this up, we can schedule the appointment. In addition, I noticed that one of your kids hasn't been in to see us, and we had asked for a follow-up on a condition that you identified. And last but not least, the social determinants of health, you may qualify for some programs there. So that visit just became, and the physician didn't have to go through a file or pull a file. And last but not least, and here's the one I love, and that is, by the way, there's a clinical trial. You've been dealing with hepatitis C. There's a clinical trial. We now have a cure for hepatitis C. And you could get that and all those worries that you had. Or it's a clinical trial for something you're struggling with. You have a medication, you're taking it daily. There's now a weekly. All of that should be served up. So all of a sudden that call, now you didn't eliminate the physician, you actually made the physician better and you gave them the information they dream about doing. Years ago, we did this in prescriptions where we said to people, hey, we've run for this prescription that you used to scribble down on a script pad. We've now done drug to drug, drug to pregnancy, drug to weight. We've told you whether it's covered by your formulary or not, whether you can waive copay. Now we're going to bring that courtesy of AI to these interactions and make it very rich. And the physicians that we are now going to be affiliated with, that 98.6, that was their dream. They said, if we could have that served up every time, we could keep people healthier, not just fix what they're calling about. And I think that's Aneesh's dream, my dream. I think it's everybody's dream of what we can do. And it's now this close. That's why we did the 98.6 transaction. That's what folks are dreaming about who are doing this. And yeah, we have to be super careful about using AI. It's no question. We have to be super careful about privacy. None of the stuff I talked about has anything to do with privacy. These are rights that you've already given to your physician. You want them to be as smart as they can be. So when your physician says you should do something, you know she's right. And that's the dream. That's what we're pursuing. And again, the Carejourney information that we get is going to take us a big step forward. And then this broader vision and the AI piece are going to take us another step forward.
Well, that is fantastic. I've been talking with Glen Tullman, CEO of Transcarent, and Aneesh Chopra, CEO of Carejourney, about a little bit about their coming together, and a lot about what's going to happen in healthcare in the future. And ending on the positive ramifications of AI. I'm still waiting for ChatGPT-3 to know what ChatGPT-4 is, because at the moment it says it doesn't know what it is, but I think they've been hiding it from it so it doesn't get upset that it's been replaced by a new and better version. But it's good to talk to you guys, because it makes you optimistic about healthcare, and we're not always, having been in it as long as we have, we're not always.
Glenn, mark the count. Matt Holt did not say something cynical. Mark it.
I love it.
We got optimism.
I got it.
We got optimism.
I'm feeling more optimistic having talked to you two, but I always do. That's great. All right, Glenn,
Great to talk to you.
thanks a lot. We'll talk to you soon. We'll watch this partnership with interest.
Thank you, Matt.
All right.
Thanks.